So my name is Darragh Kelleher, and I'm the Director of Public Health Outreach at Qure.ai. So today we've organized a fantastic session for advancing to community-led approach for community-based screening. So today, I want to give a little bit of an overview for those of you who don't know Qure.ai. Qure.ai is an artificial intelligence AI-powered solution, which is disrupting the radiology space by enhancing imaging accuracy and improving health outcomes with the assistance of machine-supported tools. So Qure.ai uses deep learning technology to automate interpretation of radiology exams, such as X-rays, but also CTs and MRI scans. So in resource-strapped settings, this has been very useful, where oftentimes the lack of expert professionals is lacking. So what we're doing is we're actually making diagnosis and the treatment process more efficient and trying to make the healthcare more accessible and affordable to patients all over the world. So Qure has been in the TV space for the last 5 years. And we've had the privilege of working with a number of NGOs and funding organizations doing transformational work through a number of community-led initiatives. Today's fireside chat will address the challenges faced by programs attempting to screen for disease in the community. You'll be hearing from leading public health experts on their experiences in navigating the challenges related to bringing healthcare to the last mile, where people live and work. So without further ado, I'd like to introduce the moderator for today's session, Dr. Yogan Pillay. Yogan Pillay is the director for the Clinton Health Access Initiative in South Africa. He's held that position since June of 2020. Before that, between 2008 and 2020, he was a Deputy Director General for the General Health Programs in the National Department of Health in South Africa. Prior to this appointment as the DDG, he held positions of Chief Director for Strategic Planning and the Director for the District Health System, all in the National Department of Health in South Africa. I'd like to hand over to Dr. Pillay to introduce a lot of the work that the Clinton Health Access Initiative in South Africa has been accomplishing. And then Dr. Pillay will introduce the rest of today's panelists, who will also give an introduction to the work that they are doing. So Dr. Pillay, over to you.
Darragh, thank you very much, and thanks for the opportunity. And good afternoon, good evening, and for those that are on the west coast of the US, good morning. So thanks very much to Darragh and the colleagues for inviting me to moderate the session. Let me start by saying that the Global TB Report for 2021 was released last week. And I know we're talking about lung health, but TB is a significant proportion of lung health. And a staggering 1.5 million people contracted TB in 2020, and that's up from 1.4 million in 2019. So you can see that the COVID pandemic has made the TB epidemic even worse than it was previously. We have a significant burden of disease. Big challenge, of course, is that only 5.8 million were diagnosed of 9.9 million who fell ill in just 1 year, which means that we have 4.1 million estimated to be undiagnosed with TB in 2020. So we have a significant number of missing cases globally. Now, if you look at South Africa, we have an estimated 390,000 new TB cases annually, and we are missing about 160,000 TB cases annually. With respect to deaths, in South Africa, we have about 61,000 deaths every year, of which about 36,000 are co-infected with HIV. So we have significant co-infection levels as well. So the challenge of TB is huge globally, second only to COVID in terms of infectious diseases causing both morbidity and mortality, and a significant burden in South Africa. What have we done in South Africa? We have tried to ramp up case finding. We have introduced the Genexpert. So Genexpert technology is really wall-to-wall in South Africa, but notwithstanding that, because it's not point of care, we still are missing a large number of people. So even those that are diagnosed will not necessarily get onto treatment. And of course, we have a significant number of people who are underdiagnosed or undiagnosed. And then, of course, through the cascade, we are also leaking people who are on treatment but don't seroconvert. So they are not cured. So, we have to look at the cascade against the 90-90-90 that South Africa adopted, similar to the HIV cascade, and fix every aspect of the cascade going forward. Some good news is that we've introduced all of the new therapies for drug-resistant TB, and South Africa has been one of the earliest innovators in both researching, trialing them, as well as taking these new new therapeutics to scale. One of the things we've not succeeded, and I'm sure Dr. Maji will speak about that, we've not succeeded yet in taking X-rays to scale, especially the portable X-ray machines, together with AI. But there are pilots going on, and Dr. Maji will speak to that, I'm quite sure. And I'm quite keen to hear the experiences of my colleagues from other parts of the world as well on these issues. Malaria has a vaccine now. It's not 100% effective. It's about 40% effective. And the WHO has sanctioned it for use of children. But if you look at TB, our vaccine is as old as the Ford motor that was the first ever motor car that the Ford production plant was able to produce. You know, more than 80 years ago, this happened, and our vaccine is that old. So it's fairly clear that we really need to ramp up prevention work, vaccines, new and shorter acting therapies for drug susceptible TB. And of course, we need to reduce the number of drug resistant TBs we have. And we think that new technologies are really critical. So I'm really looking forward to hearing my colleagues and engaging with our participants on the call. So I'll stop there, and I want to now introduce Dr. Saira Khawaja, who has spent the last 15 years working with Interactive Research and Development and its partners in piloting and scaling up primary care in communicable and non-communicable disease programs in Pakistan. She has significant experience in working on the Global Resistant TB Initiative under the Stop TB Partnership, and has focused on a number of areas in the health field. In the interest of time, I won't read her entire CV, but I'll invite her to make a 4 or 5 minute input on her work in Pakistan and with her global colleagues. Dr. Khawaja, over to you, please.
Thank you, Dr. Pillay, for the introduction. And I just want to say this is a really important topic, especially the component about it being community-led. I just briefly want to talk about IRD. IRD is an organization which has been started in the Global South. We, of course, work in Pakistan, but we work in other countries in the Global South as well. And a lot of our initiatives and our success has been sort of listening to the communities and going to those countries and seeing how implementation can be successful in those countries. I think speaking about, again, we're speaking about lung health. A lot of sort of our experience, it has been in TB screening and using X-rays, but very sort of early sort of in implementation, I think our realization was even when you have all the tools, whether, when you talk about Genexpert or you talk about AI and other things, if the community is not aware, there's always a gap between provision of services and utilization. Sometimes it's about how we as public health experts think something is a solution, but the community may not be the solution the community is looking at. So it's truly been a balancing act as we have gone into the fields and screened millions of people in Pakistan. We've had to go and listen to the community, advocate in the community, and increase uptake of these screening tools. And having done a lot of screening across Pakistan for TB, we've seen that each area requires a slightly different intervention. So rural versus urban. It's also not one size fit all. So I would really encourage for people who go into sort of large screening programs, it is really important that you listen to the community and understand what they want. And again, this is not just about TB. We've seen this with mental health. We've seen this with maternal child health, vaccine uptake. And we also recently saw this with TB and COVID integration. Again, Dr. Pillay sort of mentioned the number of cases that have been missed, but in Pakistan, we saw that as an opportunity in some ways that we went to the government and we asked them, how can we use our TB tools to facilitate COVID and allow us to also do, TB screening. And so we were able to go into the community and very quickly upfront use our TB personnel and do TB and COVID screening. This learning, it didn't come to us because of COVID. This is something, again, we learned from the years of TB screening, that patients and communities want integrated healthcare. So when we started going out and screening people for TB, and I'm sure other colleagues will speak to this as well, people want, if it wasn't TB, they wanted to know why else they were sick, what else was wrong with them. And that was kind of critical for us to think about how we can integrate other diseases. We realized when we integrated mental health that, while it wasn't lung health related, it improved outcomes, it improved follow-up in TB. When we talk, there's a lot of hepatitis C in Pakistan. So again, that was important to integrate. And when we integrated COVID, getting an X-ray was normalized in some ways as well. And so people were getting X-rayed easily and getting a COVID test, and then also getting a Genexpert test. So I think I'll summarize and sort of wrap up that I think wherever we take these screening tools, wherever we take new technology, I think we have to look at them as catalysts, and we have to really ensure that the right reactants are there. And one of them, most importantly, is making sure that the community is a part of it. Thank you.
Great, Dr. Khawaja, thank you very much for reminding us about communities. One size does not fit all, and the importance of integration and treating patients holistically. Thanks very much. I'll move now to the next panelist, and that's Dr. Philay Marji, who is the CEO of Equity Innovations in South Africa. Dr. Marji is a medical doctor with a master's in public health, and she has worked in TB for more than 20 years in different capacities and in different countries, I might add. And she's worked with the WHO as a member of the STAG as well. Dr. Marji, your 4 or 5 minutes reflecting on your experiences, please. Over.
Anyway, thank you, Dr. Pillay, and the organizers of this session for inviting me to talk about TB and also the communities. And I'm going to just share 3 examples of how communities have been engaged in making a difference towards our TB programs. I think the lessons that we have learned so far from the different prevalence surveys that have been conducted, starting with South Africa, I'll focus more on the prevalence survey that I was involved in Lesotho, clearly shows that we are not actively looking for tuberculosis. That's number one. And the second one is that the symptom screening that many of us in different programs have been relying on, where we only start testing those who have been coughing for 2 weeks, night sweats, might not be the best way for diagnosing tuberculosis early and thereby reducing morbidity and mortality. The prevalence surveys that I'm talking about in Lesotho, it was clear that more than 60 to 70% of all the people who were found with tuberculosis did not have any of the chest symptoms. However, they were identified because they had abnormalities in their X-rays. I think the same picture was also found in South Africa, where many of the people that had TB did not have these symptomatic symptoms that we've been relying on. However, one is happy also looking at the developments also from the WHO promoting more the use of chest X-rays to identify abnormalities and test people early. So that is also a good development. Then moving now from the prevalence survey studies and looking at South Africa, we've been working through the Global Fund where we've deployed mobile chest X-rays in the different provinces. And here people can either come in voluntarily to have their chest X-rays done, or anyone who's visiting that health facility on that day who would want to have their X-rays. And I'll just give you figures here from one of the containers that they've so far done 23,000 chest X-rays. And out of those 23,300 of them had abnormal chest x-rays. And to date, they've diagnosed 364 bacteriologically positive clients. That's around 10%, with 20 of them even found to have drug-resistant TB. Now, really, I think it's again evident that we need to promote that people get tested early and also have access to the tests. The issue you have brought up, Dr. Pillay, it's an important one, that the method we're using of relying on Genexpert, which in many of the countries, it's in a laboratory, it's not conducive for patients. When someone comes to a clinic sick, they want an answer there and then, not to be given a sputum bottle and told to go home and cough. Therefore, this is where now our communities come in. How do we work with our communities to make it easier for the patients, either to collect those bottles from their homes, and once they've confirmed with tuberculosis, how can the community healthcare workers provide treatment closer to their homes? Through this program of the Global Fund also, we have piloted a system where the community healthcare workers, through the agreement of the patient, they deliver the drugs to the patient homes. And believe it or not, that's all the patients are asking for. Distances to the facilities is cumbersome. It's an additional cost that we don't talk about when we mention that TB services are free. And the last one, again, is the example that has been taken in South Africa, where the the mining industry, through a program called Tackling TB, have taken an initiative of involving all miners, including the employees and the employees of these mines, to be more proactive in having access to TB screening, to TB testing, TB treatment, and TB preventive therapy. Therefore, in summary, I think we need to engage all sectors. We need to push for better vaccines. We need to engage and ensure that we have diagnostic tools that really are conducive for the clients than continue business as usual. Thank you.
Thanks very much, Dr. Margie. I think it's fairly clear that taking both diagnostics and treatment into communities is going to be key to both case finding as well as initiating patients on treatment as soon as possible, and getting them cured so that they don't transmit the TB bacillus onwards. And I think the issue of point of care, or as near as point of care technologies, is going to be critical going forward. And I think, bringing back X-rays, chest X-rays, I think is a game changer. Even though WHO told us to move to sputum, more than a couple of decades ago, I think we are now coming full circle. And I think the use of mobile or portable X-ray machines is partly a game changer. And I think attaching AI to it will increase its potential for early diagnosis, or at least for screening. Thank you very much, Dr. Margie. Moving on to my next guest and panelist, and that is Mr. Andrew Codlin. Andrew has been the M&E and Research Director for Friends for International TB Relief, FIT, in Vietnam since 2018. And he has spent more than 12 years implementing and supporting TB programs in a number of countries, including in private sector schemes. Before moving to Vietnam, he has worked as Senior Technical Officer for Stop TB Partnership's TB Reach Initiative. He's also worked with the WHO, and he holds a master's degree in public health from the University of Texas in Houston. Andrew, over to you. Thank you very much for your 4 or 5 minutes.
Thank you. So I think that I'd like to talk a little bit about the work that we've been doing in Vietnam and how we've approached this both before the COVID pandemic and also now during the times of the COVID pandemic. We are in a country, I am in a country that has a national policy that we call double X. So this is scaling up the molecular diagnostics first through a chest X-ray screen and then through Genexpert. And they've done this because they've realized that there's no way to sustainably afford the direct testing of people with TB symptoms. And also after our TB prevalence survey found that about 60% of the people who have, all of the adults who have infectious TB are subclinical or not reporting symptoms. So this is really kind of the new approach that Vietnam is taking. And FIT has been a partner with the National TB Program to try and pilot the implementation of this in the community. We currently are working in 12 of the 63 provinces in the country, and including the 5 centralized, centrally administered cities. And we take, before the COVID pandemic, there was a very thriving market for X-ray rentals, and we would take these out into the community. And we did a lot of pre-event mobilization. We worked with lots of civil society partners, quasi-governmental organizations, so like the Farmers Union, the Women's Union, the local Red Cross chapters, to really mobilize people in advance of our screening days. I benefit from working in a very structured, very bureaucratic country. And so sometimes it was even possible to deliver personalized invitations to participants to come to our events. And they had a strong incentive to come when, you know, a government body is inviting you for health screening. So we would host these events in kind of community sites, pagodas, schools, churches, sometimes parks, but most often at primary health facilities that are more like dispensaries. And we would host them on the weekends so that participants could come without having to miss work. Not always on the weekend, but I would say probably over 80% on the weekend. And we had incredible mobilization of participants. On average, we are screening more than 300 people per day on a single chest X-ray system at these sites, which is incredibly high volumes for a single site and a single chest X-ray. And I think that that kind of leads us to a new problem in our program, which is we're very concerned about reader fatigue with our chest X-rays and concerned about the quality of the interpretation of our chest X-ray images. We know that this strategy of screening with X-ray and Genexpert, it can be highly sensitive, but if you have somebody who just is too tired to read 300 X-rays in the heat all day from 7 a.m. to 5 or 6 p.m., you kind of lose that sensitivity. So we have been working with several different AI partners, including Qure.ai, to evaluate the performance of different AI technologies. We just completed a computer-aided detection landscape analysis where we evaluated 15 different AI platforms and are in the process of publishing that. But we're also looking at different AI use cases and different AI use models. So we're really interested in how we can position the AI software as a diagnostic aid for our radiologists. So thinking about how we can use the AI to triage normal images so that we can reduce the workload of our radiologists so that they can still interpret and provide patient counseling and things like that to our participants, but maybe doing that for only the abnormal cases rather than for every case. And then also looking at AI as an EQA tool. So our entire model ran for kind of 2 or 3 years, and we were very successful at this, but it then basically closed down because of COVID. Vietnam took a zero COVID approach, and we were not allowed to mobilize such large numbers of people in a single day in a single site. And so we've really kind of pivoted, and we are now doing smaller screening events using ultra portable handheld X-ray machines. We have done this integrated with contact investigations where we go to clusters that have a high density of contacts, do the pre-mobilization again and try and get those contacts in, and also have been integrating into Vietnam's vaccination campaign. So the key priority populations for the COVID vaccinations have been the elderly in Vietnam, and old men are the highest burden risk group for TB in Vietnam. So it was a nice synergy there. And so we've really kind of changed and transitioned our entire implementation model to be a little bit more nimble and to be, unfortunately, reliant on another partner to do the mobilization. But so far it's gone incredibly well. And we have a big range of throughputs and things like that. We've also started integrating COVID testing into our platforms and our diagnostic algorithm. So we do a screen for COVID and for TB at the same time. So yeah, I'll leave it at there for now.
Great, Andrew, fascinating, absolutely fascinating. I certainly would encourage you to write up your experiences into a case study to share with us, because I think you've got many, many insights on your 300 screenings per day, your use of AI, and I'm incredibly intrigued by your use of ultra-portable X-ray. In South Africa, we are having great difficulty getting our regulatory authority to approve its use, given the challenges, and that WHO is yet to give us some guidelines on how to do it. So, and the integration you talk about, I think, is spectacular. Thank you very much for sharing. Our next speaker is Dr. Jason Alakapa. Dr. Alakapa is a medical and public health professional and has over 9 years of experience in health system strengthening and research. And of course, he's got significant experience in TB. He's leading the Philippine arm of a 5-country evaluation of TB digital adherence technologies, implementing the hub and spoke social enterprise innovations in TB, and also in the private sector. So I think we'll hear a different public-private sector experience from Jason. Jason, over to you, and thank you very much.
Yeah, thank you, Dr. Pillay, for that introduction. So I am Jason from the Innovations for Community Health. So in contrast to my colleagues here from other countries, we're a relatively young organization, just short of 3 years old, but we've been trying to disrupt the health infrastructure space in the Philippines. So basically, ICH, as we call our organization, is a public health delivery and implementation research organization. A lot of the work that we do is in TB, especially in private sector engagement. Although on the side, we do have works on COVID-19, hypertension, and HIV. So as our name goes by, Innovations for Community Health, one innovation that we do try to bring in the Philippines is AI-led, AI-aided chest X-ray radiography, as we do active case finding for tuberculosis. And we are fortunate enough to work with various stakeholders. So we do implement different case finding activities for the Global Fund. We do case finding activities for USAID. So we work with various partners. So interestingly, in the span of a year and a half, we've been delivering AI-aided case finding activities in different settings. So we do bring our AI screening in communities, targeting vulnerable patients. We also bring our AI screening in hospitals. So we serve as an intensified case finding activity, augmenting what we have in our tertiary or big public hospitals here in the Philippines. And another innovation that we have brought into these hospitals together with AI is what we call as COVID-19 TB bidirectional screening. So this is something that we're trying to pilot and model together with USAID so that we are able to detect those missing cases, especially in this challenging times of COVID-19. Another area where we brought AI screening is the different workplaces. And when we say workplaces, we're talking about both formal, the big companies, and also the informal ones. We're talking about transport groups, fisher folks, etc. So we do try to set up mobile screening activities, and we bring AI. And the big advantage that AI brings into these mobile screening is definitely shortening the turnaround time. So instead of waiting for the official reading of chest X-ray, which might take within the day or another day, and the patients who are presumptive by X-ray would need to come back to be tested, we could now do it on the same day. So it's more of modeling a one-stop shop facilities, which I think my colleagues here would be very much familiar with. So the beauty and the challenge in the work that we do is trying to navigate the different stakeholders, of course, different funders, different partners, the public, the national TB program, and also the private sector, the different workplaces would have different requirements, different policies. And one experience that we found useful is basically trying to provide evidence as we model these different interventions. We do implementation research alongside with our implementation, and we try to translate them into guidelines, clinical practice guidelines that we advocate for these different stakeholders, especially the national TB program, to adopt. Another interesting thing that perhaps we can offer or we do with AI is that we do have in facilities, as mentioned by Dr. Pillay. We do have our social enterprise clinics, which caters to our private providers, the standalone providers here in Metro Manila, the Philippines. So we do have AI as well in our facilities. And instead of giving the AI-led screen, the AI-aided screening for our perspective, for our TB patients, here we, for free, this is more of a for payment model. So we do not give it for free, but for a minimal cost. But we find very interesting lessons in which, there's an increased uptake in terms of referrals from our private sector partners. So now we see that our private sector partners, especially our pulmonologists, they see value in adding AI to screening our patients. Oftentimes we see them excited about this technology, and this is something that we hope to scale up. So moving forward, perhaps I would just like to leave this opening part by saying that innovations should always be fit for purpose, meaning it should be targeted to the pain point of our stakeholders. And at the same time, it should be fit for context, depending on the stakeholders that we are engaging. I'll leave that for now. Over to you, Dr. Pillay.
Great, thanks so much, Dr. Alakapa, especially for your private sector. I really like to hear more about how you are going about encouraging workplaces and employers in the formal sector, and of course, how you're doing it in the informal sector. And I think it's critical that evidence from your implementation research feeds into clinical practice guidelines. And I think that might be useful for WHO as well to hear from the ground up, how you're doing it. So thanks very much. I'd like to thank my 4 panelists for a fascinating description of the work they've been doing. There've been a number of questions on the chat, and I will try to direct them. And for some of them, I think I will ask everyone to comment on. So one question which I will ask Dr. Maji to respond to. Dr. Maji, how is Genexpert useful for diagnosing extremely drug-resistant patients? And what are the challenges? And if it can't, using the current Genexpert technology, how do we go about diagnosing extreme drug resistance? Dr. Maji, over to you.
Thank you, Dr. Pillay. I think we all know that Genexpert does help to a certain extent to identify clients that have got RIV resistance. However, in the TB program, they've also brought it up several times that South Africa has very high rates of INH resistance, which again end up delaying the time to initiation of treatment. So the patient or the client presents to a district, Genexpert positive RIV resistance. The test has to be further sent to another higher level where second line testing has to be done to confirm whether there's resistance to other drugs. These again are further delays in initiation of treatment. So there is definitely a need to see how best can we diagnose resistance beyond just rifampicin at lower levels to minimize delays of initiation of treatment, especially for clients with XDR-TB, who are usually more sick, and definitely a delay in a week might unfortunately end up in death.
Thanks very much, Dr. Maji. Dr. Alakapa, can I ask you, you mentioned high-risk groups. How in the Philippines do you define high-risk groups before you target them for case finding? Would you mind responding to that question from one of our colleagues on the chat?
Sure. Yep. For the Philippines, the definition of high-risk group is highly influenced by the findings of our 2016 National TB Prevalence Survey. So according to this National TB Prevalence Survey, which I think the results was just recently published last year, high-risk groups would include those male workers in the informal sector. There are certain industries which are more prone, such as mining, such as those exposed to construction. Other high-risk groups that were identified by the National TB Prevalence Survey included people in incarceration, those in prisons, and those coming from the urban poor, basically those coming from the lowest socioeconomic quintiles here in the Philippines. So that's how we systematically target these people by engaging the local government units and also engaging different community-based organizations who work closely with these groups.
Great, thanks very much. Dr. Khawaja, can I come to you and ask, how are your programs that focus in rural areas different to the urban areas? You know, how do you do TB screening in rural areas that's different? Because I think I fully agree with you that one size does not fit all. So how do you tailor it to the urban versus rural areas? Over to you, Dr. Khawaja.
So I think what's important is, in in urban areas, of course, you can find a lot of settlements close by. It's easier to sort of, park a mobile van somewhere and get lots of people to come in. I think in rural areas, you have to understand the structures over there, whether they're villages or other smaller communities. And I think the acceptance of the fact that while I can take Karachi as a complete city, if I go into a rural area, each smaller village is a small community on its own. So the principle of one size does not fit all. I think understanding sort of the community structures. So a lot of, they have leadership. They have their own leadership structures within those areas to understand them, to engage those individuals. So I think, again, the important sort of rule of thumb is wherever you go, whether urban or rural, is you have to understand the dynamics. You have to understand the people there. We've seen in rural areas, even across the road, if you go one side of the road, the other side of the road will not accept your screening because they have a different leadership structure. So I think it's a lot of respect for the different structures that they have and take it there. And once they see that you're coming in to facilitate, so, I may be wanting to go in with TB screening, but they may be worried about snake bite in children. And that's what I need to lead in from. Because they don't see TB as a problem. They see their children dying from snake bites and rabies as the problem. So again, I think that's a really important thing when we talk about even integrated care, that you must go in with what those individuals think their challenges are, as opposed to saying, well, I think you have a lot of TB, so let me come and screen you for TB.
That's very, very good advice. Thanks, Dr. Khawaja. Andrew Codlin has posted some responses on the chat, and I'll encourage you to read it. Andrew, do you want to summarize some of your comments on the chat for people who might not be able to access the chat? Over.
Sure. I apologize for kind of jumping in. I thought, anyway. In terms of participant mobilization, it's really important to understand your local epidemic and to figure out what populations are contributing the most to your overall TB burden, or which populations have the most acute access barriers and needs that can be overcome by taking your x-rays out into the community. And we did a mapping analysis and used some of the data from our last prevalence survey to figure this out. We also have done a lot of integrated health screening to kind of reduce the burden, to reduce the stigma associated with a TB screening only event. And I would say at almost every single event, we do diabetes and blood pressure screening. And then when possible, we can do COPD and asthma screening. And now obviously COVID screening. We've had some challenges with prioritizing and getting TB back on the agenda in the times of COVID. We had a very, very strict, I really cannot emphasize how strict our lockdown was in Vietnam. For 3 months, we were not even allowed to leave our homes, for any reason. Kind of proposing to the government the integration of TB and COVID and other health services really kind of cracked that door back open for ensuring that TB remains a priority in the screening and the mobilization that's going on. We've seen something in the past 6 months in Vietnam, about an 80% decline in our TB treatment coverage because of the big Delta outbreak that we have right now for COVID. So yeah, we've really seen that integrated service as a way to get our foot back in the door and keep TB as a priority. Over.
Great, Andrew, thanks very much. Yeah, no, I mean, what's true, I think, is globally, where we've had significant lockdowns, we've seen significant reductions in screening, in testing, and in initiation on treatment. So, you know, we've really been taken back, I think. In fact, some estimates suggest we've been taken back 5, maybe even 10 years, you know, and that's how long it's going to take for us to recover from the impact of COVID on the TB program. Philippe has kindly posted on the chat some additional information on the Genexpert and its ability to diagnose drug resistance like INH and the fluoroquinolones. So I'll ask you to focus on the chat as well, so you'll get a bit more information. There's another question that I want to pose to all 4 of the panelists, and that is, what's the willingness, in your experience, of community members taking a chest X-ray out of our facilities? Because, you know, typically you will go to a facility, whether it's a clinic or a hospital, and get X-rayed, and there's a certain amount of privacy there, etc. But now we are taking these into the community, right? And mobilizing, as Andrew said, hundreds of people to come in and get X-rayed, kind of quite publicly. So the key question then is, you know, what has been the appetite? And I'll start again with Dr. Margie, and then go to Jason and Dr. Kawaja, and then to Andrew. Dr. Margie.
Thank you, Dr. Pillay. I think it's, of course, as I mentioned, we currently have 5 containers placed in different areas, but we have not had a problem of people being encouraged to go to have their chest X-rays done. They actually volunteered when we tell them that the X-rays are free of charge. They will be able to detect if they've got abnormalities in the lungs, which might be TB related or not, and they do come forward. The challenge is when now we find abnormalities and now ask people to either provide a sample, then there's that hesitancy that I didn't come here, I was not sick, whether or not, but as them accepting that has not been a problem. I think still talking about the X-rays, the other good thing is that we've placed these X-rays where access to services has been limited. So even the communities seemed encouraged that for the first time, they can just go and have some tests being done, either having their chest X-rays done, and through the districts also, we place, for example, different tents where blood pressure is checked, they can be screened for diabetes and HIV. So it's again, it's just an opportunity of making sure that we bring services as close as possible to the communities. And earlier on, I think I also mentioned I forgot to mention that one of the things that really I think I've been a game changer has been the use of AI. With limited radiologists, with limited doctors, the radiographers and the enrolled nurse and the community healthcare workers, literally it's a team of 3-4 people who are able to resolve a lot of issues than expecting highly trained staff to manage them. So AI has really helped in ensuring that the results are interpreted as soon as possible and action is taken. Thank you.
Thanks. Can we go to Jason? Same question, Jason.
Sure. Just quickly for the Philippines, some important things that I would like to highlight. First, we've seen that different settings would yield different results. So definitely with the advent of COVID-19, we saw a drop of patients going in for these case finding activities. Pre-COVID, we've been seeing 100 patients a day in one screening activity in one particular place. But when we restarted around last year or early this year, we've only seen 50 or less than 50. So that represents more than 50% drop, somehow similar to the 60 to 80% drop experienced in Vietnam, also with the Philippines when the lockdown started. So we've seen now that we're trying to ramp up our operations. People in the community setting would have a higher tendency to go out and join the screening activities if it is in the community. But if it's in a hospital setting where we do the case finding activities, they're less likely to do. Most probably this is due to the perception that they would probably contract COVID-19 if they go to these high risk hospital settings. Another observation that we have seen, of course, incentives do work. In some of our activities where we implement with community-based organizations, they do give, let's say, a pack of rice. And this is something that people are really coming in to do. I mean, this is a really good incentive for people to come and join the activities. Another thing that we've seen increasing our uptake of these screening activities included the TB COVID collaboration. So we do bi-directional screening, and when we sell these case finding activities, we also try to pitch in COVID-19 because COVID-19 is more proximal to the needs, to the interests, to the fears of the people on the ground. So if you say COVID-19 and you tie TB with it, they're more likely to uptake. Another good thing that we have seen is that really works on the ground is what we call as master listing. So if you do have partners on the ground, we need to make sure that we have these names that will show up on that day. So this makes sure that the implementation would be efficient, that we will be reaching that required number. And perhaps, well, I will agree with Dr. Makatji that AI has brought a lot of positive things, especially in terms of shortening the turnaround time, trying to fill in the gaps where we don't have those highly specialized skills such as radiologists. One thing that we've been seeing on the ground is the expectation of people that if you underwent a chest x-ray, you should have an official reading. Here in the Philippines, if you went through an AI-read x-ray, you don't have an official reading yet, because only radiologists here in the Philippines can give that. And that's something that somehow affects their acceptance. This is something that we're looking into, and we hope to learn more so that this would be really an important thing to unlock as we scale up the rollout of AI here in the Philippines.
Great, thanks so much, Jason. Can we go to Dr. Khawaja, please?
Thank you. So I think I'll speak a little bit about pre-COVID. We've been implementing across the country using mobile vans, and what we saw is that majority of the screening events, we had a larger proportion of males and a lesser proportion of females come to these screening camps. And again, that's very cultural. We saw lesser women come in. Certain community initiatives using young schoolgirls to sort of advocate helped sort of increase the uptake of women. But again, we do see a difference between men and women accepting community-based X-ray screening. On the flip side, we see, there's a higher rate of TB in young women in Pakistan. We do see a higher uptake of X-ray facilities within facilities by women. So it really is the stigma associated with publicly getting screened and tested is still pretty huge. So that is challenging. As Jason said, COVID was a blessing in some ways, because when we tagged it with the COVID-19 co-screening, because people didn't want to go to facilities, we even then at that point had more women coming to the mobile van facilities, because the fear of going to hospitals and being diagnosed with COVID and then being put into quarantine was so high that women did not even want to approach facilities at all. So all in all, I think the acceptance is pretty high, but even like if you want the higher utilization, you have to make sure, again, the timings of these, where you offer these X-rays is, looks at when people are available. So men will not utilize X-ray services if you offer them midday, similar to what Andrew mentioned. We have to do evening shifts, or you have to do weekend shifts. So again, it's less of acceptability. Sometimes it's also that you have to think through the timings and making sure your people are not missing their work days, etc., when you deliver these services. Thank you.
Thanks, Dr. Khawaja. Dr. Khawaja, while you have the floor, can I ask, there's been a question about whether or not with Genexpert, even though it diagnoses a whole range of drug resistance with various drugs, everything from kanamycin, amikacin, etc. Do you still need a culture? What's been your experience? And I'll ask Dr. Margie and Jason the same questions as well.
So
and before we come to Andrew.
Sure. So right now in Pakistan, they've been using the Genexpert, which is just showing RIF resistance. So when they come to the facilities, sometimes they even get a repeat Genexpert test done. Just because if they're new cases, and unfortunately in some of the facilities, they do a repeat Genexpert and then they do a culture. So again, I think it's about the acceptance of these new tests and how people look at them. But right now, yes, they are still doing cultures. It's again with tools, as people sort of belief in them increases. It's the same way with X-rays. When AI it gives a result, people still go to a reader and want it read. It's the same thing, and it will take time and evidence for people to sort of accept that change.
Great, thanks. Dr. Margie, your experience with culture?
I'm really not 100% sure, because I think there are huge variations also from one province to another, what is being used and what is not being used. So maybe let me leave that one and not comment.
Okay, thanks. Jason, in the Philippines, so what do you guys do? Do you send for culture as well?
Sure. In the Philippines, we do have variations of quality of care from the public sector versus the private sector. The National Manual of Procedures, or the clinical guidelines for the NTP, says that Genexpert is the first line of confirmatory test for our patients. So that is being done in the public sector. But the private sector, we do have a large fragmented private sector. That's a different story. A lot of them rely with chest X-ray. I'm sure similar experience elsewhere, and they end up having clinically diagnosed. As for culture, we're no longer using it. In fact, we only have a handful of culture facilities, TB culture facilities here in the Philippines.
Great. And just to be clear, when we're talking about culture and the need for culture, we're talking about drug-resistant TB, not drug-susceptible TB, which is easily and reliably diagnosed with expert. Andrew, over to you.
Thanks. So I agree with a lot of the comments that the panel has said about acceptability and getting people to come to your screening events. I would just say that we ran a pretty large multi-year trial where we were piloting for the first time this double X algorithm, X-ray to expert. And we initially thought that we were going to get people to go to health facilities, and then our job would be much easier. And in reality, we saw that going to a health facility was actually a huge barrier in our setting, and that only about 1/3 of the people who were actually referred ended up going. And a lot of the people who made their referrals or who materialized were the very sick, and so maybe the easiest to catch or the lowest hanging fruit. So we've seen very high acceptance with our mobile chest X-ray events in the community. I think the comment that Saira brought up about women is also very true in our setting. We see a lot of hesitancy, and we really struggle with sputum collection at our events for women. So we've designed some animated sputum collection guides, and we've trained a whole cadre of healthcare workers on how to coach people to give good quality sputum specimens and things like that. I just would add one more comment, which is, even when we have high participation, we still don't have perfect coverage. And in one of the last screening events that we did, before this last lockdown and before we had to pivot to the COVID approach, we were able to take mobile ultra portable X-rays out, and we had a location on an island outside off the coast of Vietnam. and we were screening in what's called a commune health station. So it's really a dispensary. It has no X-ray equipment, no diagnostic equipment. And we screened there all day. And we realized that there were many people from the census data that still had not come. And so we actually took the X-ray up the hill into I don't want to say the forest, but up the hill into the island, and actually started screening people in their homes. And we really took it out into the middle of nowhere. So I think that even when you have really high mobilization and you have good acceptability, it's never perfect. And I think that these new tools that are coming out are really just a really fantastic resource to try and reach the people who are really being missed. And I think in that particular context, there really is a health system and a human resource challenge. There's limitations. So in that setting, AI as a replacement for a radiologist worked very well for us, and we were able to screen people in really kind of the most remote of remote settings. Over.
Great, Andrew, thanks very much. I want to hand over to Dara, one of our organizers, for a few minutes as we move towards closure. And Dara, back to you.
Thank you, Dr. Pillay, and thank you to all of the panelists who've added inputs. And I think from Qure.ai's perspective, what it really shows is beyond a software solution, there are so many more complex problems to consider. And I think this is a humbling for us to be able to host a group like yourselves to explain some of these. But a couple of things have really kind of played in my mind. And I see, Andrew, you've mentioned that one of your colleagues is presenting at the union. And I think one to kind of say is, I think this week for me and the team here at Qure, we're going to be learning a lot at the union conference. So I'm looking forward to that. But just there was a question, Jason, in the chat from Rachel, and she was asking about, how do you show the results to patients? And I think you said something similar around the lines of, patients, there's an AI result, but how does this transition into a report? So I know we see a lot that even with digital x-rays, they still want printers and patients want films. So this is one thing. But in terms of automated reports, either for referral for specimen sample, can you shed some light on some tools that you're using for that, or what could be beneficial in the future to use?
Yeah, we do it differently if we do X-ray screening in facility with AI and also out in the field. If it is out in the field, a lot of the things that we do are still modeling projects. And also we try to pitch in AI with the usual ACF activities here in the Philippines. So having said that, if we screen people using AI, we just tell them that the results are negative. There's no significant finding at all. And there's no physical evidence that we are giving these people. Moving forward, I think one good thing that we might want to consider is having that physical sheet that, perhaps physical or online, that might increase the acceptability of such screening. But for facility screening using AI in our social enterprise clinics and labs and diagnostics, we do have a radiologist reading it. So we have the results of AI in the official reading. So it's a different story. It's like a normal, facility. So yeah, I think this is still something that we are unlocking, Dara, and this is we will be looking into more closely in the coming months or years.
That's great. Thanks, Dr. Galapapa. And Dr. Machi, for yourself, in terms of on the mobile containers that you're referring to, are you using any sort of report that you're giving to the patients, so whether they're presumptive or not?
But yes, the patients do get, the clients do get feedback. However, we learned that we should not rush to associate the abnormalities with TB, because after giving sputum, if they are negative, the clients become more anxious to say, now you said I'm sick, what is wrong? So we do have local just pamphlets to say, for those that had abnormalities, to say there are abnormalities in your lungs that will need to be investigated further. I think that is also helpful. But from the question that was asked here, we really, as we promote using the X-rays, we need to find a way of relaying the results to the clients in a way that will not leave them more anxious, because not all abnormalities will need treatment, at that time, especially in a country where we have a lot of clients with silicosis, which we're seeing in one of the provinces, that the clients have abnormalities, but it's not that they need treatment. So we need to be careful how we interpret and what do we tell the clients. However, there are pamphlets that we distribute in these containers. And a quick point still on the use of the mobile x-rays. We're also piloting, one of the containers actually has a Genexpert installed. So once the x-ray has been found abnormal, the client is able to produce a specimen. The specimen is collected there and tested. And even though the numbers might not be huge to date, for the first time, a person is able to present to this health facility within 4 to 6 hours. Those clients are initiated on treatment if they test positive. So that is again the lesson that the placement of our diagnostic tools still need to be reviewed to reflect and reduce the time from infection to treatment initiation. Thank you.
Thanks, Dr. Machi. That's very great. And I think there was another question in the chat as well around, have any of you seen any trends in increase in clinically diagnosed TB versus microbiologically diagnosed with more tools being available? How has that been changing in your respective projects? Go ahead, Dr. Machi.
Okay, so I think the interesting part here really is that with the use of digital x-rays, are we going to end up over-treating people for TB? Because many of the clients who test negative for Genexpert are referred for further assessments. And we do see an increase in patients being treated for extrapulmonary TB or for other conditions. So there is an increase, but we just need to be careful and not over-treat people who actually don't have TB, but have lung abnormalities.
Great, thanks, Dr. Machi. And maybe for Saira to Dr. Kwaja to add in, and then I think Dr. Pillay has one final question for you all before we wrap up. We'll try to keep it as close to in time as possible for your schedules.
Sure. Thanks, Dara. I just wanted to add, I think in Pakistan, what we saw, at least in the city of Karachi, we saw that the bacteriologically positive numbers increased with the increase in adding AI tools and adding the Genexpert. As Dr. Machi said, I think we have to be careful about overdiagnosis. And this was, again, lessons learned within sort of the first year where we put in, you put in clinical quality audits because you have those x-rays and sort of you're checking the systems as you go forward and giving feedback to the doctors where there's potential overdiagnosis happening. So I think as part of any health systems, those things need to be incorporated in, that you want to move with the pace, but then you have to have the quality systems in place to make sure overdiagnosis is not happening.
Thank you, Sarah. That's been fantastic. And if I'm going to ask you just to turn on your video, and also Dr. Machi for this final, I think, closing question from Dr. Pillay before we wrap up.
Dara, thanks very much. So I have a very easy question in closing for all the panelists. But firstly, let me thank them for both their inputs and for responding really so comprehensively to the questions that participants have asked. So starting now with Jason and going forward to Saira, here's the same question to everyone. We have to eliminate TB as a public health threat by 2030 or sooner, and that's 9 years or less away. What's the one game changer you would like to see scaled up globally? Let's start with Jason. Jason, what's your game changer to eliminate TB as a public health threat?
Integrated one-stop shop screening to treatment facilities.
Great, thanks very much, Jason. Andrew?
So I would probably say short course TB preventive therapies. I think that that's something that really is not being done at the scale that it needs to be done right now, and has potential for huge impact on future incidence rates. Over.
Great. And if we can go to a fixed dose combination for TB preventive therapy, it'll reduce the burden on our patients, or at least people as well. Thanks very much. Rafila?
So I have 3. New vaccine,
Mm-hmm.
point of care test, new drugs to shorten the 6 months.
Great. Thanks very much. And finally, Sarah?
And I think between the other 3 panelists, they covered everything. But I think, we've seen it in COVID now, and I really hope we can make those advances like home-based testing, vaccines, normalizing TB like COVID has been normalized. Everybody's kind of willing to do all the things we've been sort of screaming about for the last so many years. So I think, I think that would be most important.